Okay, let's go ahead and get started. Just in the interest of time, so that way you can get on with the lecture from our wonderful speaker. To start things off, hello and welcome everyone to this month's UCLA Tarjan Center Distinguished Lecture Series. I'm Jasper Estebillo, Training Director of the UCLA Tarjan Center, which is our University Center for Excellence in Developmental Disabilities. On behalf of the Tarjan Center faculty and staff and our co-sponsors, the UCLA Center for Autism Research and Treatment and the UCLA Intellectual and Developmental Disabilities Research Center, it's my pleasure to be here with you all and to introduce our speaker, Dr. Jill Fodstad. Dr. Fodstad is an associate professor of clinical psychiatry in the Department of Psychiatry at the Indiana University School of Medicine. Her clinical and research interests focus on the development and dissemination of models of identification and treatment for co-occurring conditions in individuals with neurodevelopmental disabilities, including self-injurious behaviors, regression, and psychiatric conditions. Dr. Fodstad is presently the clinical director of the Early and Emerging Self-Injury Clinic at Riley Hospital for Children, and she's the director of psychological services for the Autism Biobehavioral Unit at the Indiana Neurodiagnostic Institute. She's presently the site PI of an NIH-funded multi-site study investigating biomarkers for Alzheimer's syndrome in adults with Down syndrome, and is a PI on a foundational study aimed at developing autism-focused assessment and treatment protocols for general acute psychiatric medical settings. Dr. Fodstad is also on the editorial board for the Journal of Autism and Developmental Disorders, and is the editor-in-chief of the Review Journal of Autism and Developmental Disorders. For all of our attendees, closed captioning is available. You can click on the live transcript button on the toolbar on the bottom of your screen, or if you prefer to adjust the text, you can also click on the link that we will put in the chat for additional captioning. Throughout the talk, as we know, we will have many questions. Please note to submit your questions into the Q&A function, so that way we can address them during our live Q&A with Dr. Fodstad in the last 10 minutes of our talk. And with that, we will move on to the lecture. Please join me in welcoming our speaker, Dr. Jill Fodstad.
Thank you so much for that warm welcome. I appreciate that. I am so excited to be here with everyone that has joined. And am also excited that people are really jazzed about this topic. I think that hopefully today, you'll all be able to take maybe a few things from some of the things we talk about, some of the few ideas or strategies that we've implemented at the hospital that I am presently at, as well as across our healthcare system. And certainly, I'm excited also for the Q&A at the end. So today, what I'm going to be talking about is treating severe behavior or psychiatric crises in autistics admitted to emergency medical or inpatient psychiatric settings. It's more than just reducing behavior. And I think that's vitally important because certainly, behavior problems do occur with individuals with autism, but when they are admitted to these psychiatric settings, I think that taking a more family-centered approach is generally the best strategy. And we'll talk a little bit more about that. But before we begin, and I share you my outline, I want to give you a few disclaimers. So number one, I am not going to profess myself to be an expert on this topic. Yes, I do research in this area, and yes, I have a lot of experience in treating severe behavior disorders and co-occurring psychiatric problems in autistics, in both specialized settings, specialized psychiatric settings, as well as in generalized settings. But I don't think I could ever consider myself to be an expert in this area. So I hope you will forgive me for that. And number two, this is more due to COVID. I have one of my children at home, my husband, a 16-month-old. My husband is home as well, but my little son loves to Zoom bomb. Anytime I'm on some meeting or an appointment, he loves to make a little announcement or screech or whatever. So if you do hear something in the background, that's probably him. So just want a few disclaimers before we begin. So here's my outline for today. So I'm going to give a brief background on acute psychiatric needs for autistic individuals, as well as those with intellectual and developmental disabilities. We're going to talk a little bit about methods of assessment and treatment. And then also embedded within this point too, we're going to talk about basic strategies that anyone, certainly non-specialists or non-experts in autism, can use, right, in these very specialized settings. So I think to kind of frame this talk, the first place we have to start is, I think most of us are well aware, no matter what our background is, no matter what our interest is on this topic, most of us know that taking care for individuals with autism takes a lot of money, right? So in 2021, the estimated annual total healthcare cost community, well, it was 2015, was estimated to be 268 billion. That is a lot of money. And when you look more at kind of how that money was dispersed, what we really see is that, a lot of that money was dedicated to behavioral health or mental health care needs in those with autism, right? We know, one, individuals with autism have a high level of behavior problems and psychiatric needs. And while that is a broad number and certainly a large number, really what our topic is focusing on is that small sect of individuals, so that 10 to 15% that need inpatient psych admissions at least once during their lifespan, okay? So we're talking about those persons who have behaviors or psychiatric needs to the point that they need an inpatient admission due to safety towards, maintaining safety of themselves, safety of other individuals. Other things that we do know is that, when we compare samples of non-autistic to autistic peers, those with autism, they stay longer in these settings, and they also, it costs a lot more money to provide high quality care. In 2006, now this was a very long time ago, in 2006, not that long ago, but this study kind of looked at the number of kids that presented to the emergency department and kind of where they were discharged to. Were they discharged home? Were they discharged to an inpatient setting, right? And those with autism had 11.9 times as many psych hospital stays, and they incurred 12.4 times the cost, right? That's a very interesting number, right? And there has to be some reasons behind that. In adults, those numbers are very similar, right? There hasn't been as much research in this area for adults, but what we do know is that when they are compared to non-autistic peers, they're much more likely to present to the emergency department for psychiatric reasons, right? And so we can then infer that it's a more costly admission, and they're probably going to be admitted potentially more times than their non-autistic peers. But again, there's not a lot of data here. So just kind of extrapolating on what we know in the child literature. So when we think about it, what are those common vulnerabilities in the autistic community that increases the likelihood that they're going to have behavioral health challenges, and then further increase the likelihood that they may have or may need a psychiatric admission? First, I don't think that any of these are things that we're not very aware of. But again, just trying to frame this talk, one, the autistic community, whether they have profound autism or whether they have high functioning autism, do have receptive and expressive language difficulties. And when we look at what are factors that may predict or correlated with the occurrence of behavioral problems like aggression or self-injury or property destruction, by and large, we see that these behaviors are used as a form of communication, right? So if a person has difficulties getting their needs met through communicating, I need help, I don't feel well, I feel unsafe, I don't want to do my homework, or whatever it is that is going on at that point that they need to communicate, sometimes a behavior problem can fill that void or can take on a communicative function, right? The number two area in those with autism that really increases the likelihood for behavioral health challenges are social difficulties. Again, these are inherent within the diagnosis, but again, are also related to reasons why a person with autism might have behavioral health needs. They might have a reduced interest in social approval, and certainly they have theory of mind deficits. So their ability, one, not only to understand their own emotions, but to understand and interpret and respond to the emotions of others is definitely hindered, right? And they need maybe a little bit more help or a little bit more training there. And so because of that, it may be related to why behavior problems are occurring. And then kind of that last step is kind of these co-occurring difficulties, right? And so things that we know that are highly correlated with individuals with autism, we see a high level of inattention, a high level of hyperactivity. So those ADHD symptoms, irritability, being anxious or fearful, or they might have these undiagnosed or untreated medical concerns. And because of that, it may be related to why they have, I am so sorry. My phone is going off like crazy. So I'm going to cut that off. And I do apologize, but I tend to get a little distracted. So that may be reasons why they're going to have behavior problems. And so I know most people have seen this iceberg kind of analogy, but I think this is definitely highly relevant to those with autism. Is like what we see on the surface may not actually be what's underneath, right? And if we're thinking about how do we best serve the needs of autistic individuals who have acute psychiatric needs, we really got to understand what's beneath the surface. And once we do, or once we're better able to, it's really going to help inform better treatments in these settings. So other additional factors, a lot of autistics have a very long history of behavior problems and behavioral difficulties or co-occurring psychiatric comorbidities. So there have been some studies that looked at very young kids that are high risk for autism and have found that 20% might have self-injury or aggressive and disruptive behaviors as early as 2. Right. And if we looked at that study and other studies related to that one, we see an increasing trajectory across the lifespan to some point. And the same thing when we look at these other co-occurring conditions like ADHD symptoms, irritability, having some fear, anxiety. Again, we see a higher level of really young kids, high risk for autism, who are engaging in these behaviors, right? Compared to not only their peers that just have general developmental delays, but also same age peers without delays. We also see parents who have a high level of caregiver burden or distress, right? And so if you have a child, whether they are under 18 or it's your adult child and they have autism, they have a high level of behavior problems or psychiatric needs, that can cause a lot of distress, that can cause a lot of burden, right? And so it may be more likely, I've met a lot of parents that have been like, you know what? I just can't handle this anymore. Like, I know that you're telling me that this is the best plan of care and that if I do this, things will get better. But you know what? I'm just tired at this point and I can't keep myself safe. I can't keep my son safe or my daughter safe, and I can't keep my other family members safe. That, right now, this is the best bet for us, right? Going with my child to the emergency department for psychiatric reasons, at least that gives me some respite, right? At least that gives me a chance to get things together. I had one parent that said, bringing my son to the hospital gives me a chance to patch the holes in my wall and to clean the fecal smearing off the walls also, right? And if that's what it takes at this point, to be able to do that and to give myself some peace of mind, I'm going to do it. And I 100% understand that, right? So we have parents with a high level of distress and maybe they have community-based services and maybe they don't, but regardless of that, their child is still having behavior problems to the point that they feel they can't safely manage them in the home. I think by and large, a huge factor that increases the likelihood that individuals with autism do present to the emergency department and are admitted to acute psychiatric settings is that, I know certainly in the state of Indiana, where I'm coming from, but across the United States, and even people I've talked to in other countries, services at all levels, whether they be crisis, whether they be preventative, whether they be wraparound services, are really limited compared to the actual need. And I think certainly the COVID pandemic has really brought that to light, not just for autistic individuals, but for mental health needs overall, right? That the amount of services that we have to provide evidence-based psychiatric care is really minimal, and we need a better focus on that moving forward. And then the last additional factor, and I imagine that I am probably missing quite a few here, but just kind of thinking about the main factors, is that we have a lot of hospitals or behavioral health care services mismatch, right? So, kind of thinking about a lot of providers in these settings feel unprepared to care for autistic patients, right? They may feel, this is very important to do, but I feel that as the healthcare provider, really don't know how to provide good care. And so we also see there's lots of data to support, continued crisis presentations to the emergency department, or readmission to acute psychiatric settings for individuals with autism. It's not necessarily at a higher rate than their peers, maybe a little bit. That's not that statistically significant, but we do see that, at least with respect to the hospital systems, kind of where they're at now, is that a lot of providers feel nervous or scared or ill-equipped to provide care and high-level psychiatric care in acute settings to autistic individuals. So what are these predictors of psychiatric hospitalizations? And I will say we're going to have two slides, one for children and one for adults. They're very similar, okay? But again, trying to frame this talk, what we do see, certainly one, individuals who have problem behaviors like aggression or self-injury are more likely to be admitted to psychiatric hospitals, right? These generalized settings, generalized crisis settings. I do think that there are some very interesting findings in the study by Mandel. One, single parent homes, right? And I had a friend that read this and kind of told me, well, that sounds very odd. Why would that be? I'm like, well, think about it. That parent may have very limited social support, right? So it kind of leads us back to that high level of caregiver burden or distress, right? We also see those with co-occurring behavioral health symptoms like having depression or obsessive compulsive disorder, having more severe autism symptoms maybe, or greater severity of communication deficits or adaptive functioning. We also see these other kind of potential medical issues like sleep problems possibly being related to reasons or predictors of psychiatric hospitalizations in autistic kids. And again, looking at the adults, that is not that different. We see one, family distress, negative life events, being on psychotropic medication. That would more often than not make sense, right? Aggression, co-occurring difficulties like intellectual disability or mood concerns. So most people would think, well, if that's the case, right, and we have all of these factors that are kind of fighting back against providing good care in emergency departments or acute psychiatric settings that are not specific to individuals with autism, then maybe we should just have these autism-specific settings, right? And so what you're going to see here are the number in the United States of actual autism-specific inpatient behavioral health units, right? I think some things to point out. There's not a lot, right? There's certainly not a lot on the West Coast where most people joining here at. There are more on the East Coast, Midwest, kind of not a lot either. So if we think about, 10 to 15% of autistic individuals, regardless of age, need inpatient psych services, I don't think that this is enough, right? And I also don't think that we're going to see, now, certainly I do think that there are a lot more in the works. So over the next 10 years, we'll probably see some more popping up on this map, which will be great to see. But I also don't think that just having autism-specific behavioral health units is going to be enough. So we've really got to think, how can we improve the care in general settings, in general psych settings? I do also want to point out the vast majority of these have really long wait times. I only know 2 of these that actually take kids with autism immediately from the emergency department. And there's only 2 on here that actually are for adults or have adult services, right? So again, thinking about that lifespan approach to care, there's not a lot of acute psych services for individuals with autism. So kind of thinking about that, I know that you heard on my introduction that I have a small foundational study that kind of is looking at this. So one of the first things I really wanted to do is kind of think about, well, if we need to improve care in general settings, where do we start? Where do we begin? And that's really looking back at the literature and kind of thinking about, well, what is out there? There's not a lot. And number 2, we also thought about, well, why don't we talk to the people that would know the best? So we're presently recruiting, but we have talked to about 40 individuals, 40 stakeholders, and that runs the gamut from nurses, social workers, physicians, including psychologists and psychiatrists, parents of autistic individuals who have been admitted to non-specialized acute psychiatric settings, meaning they've gone to these general psych units, as well as autistics who have been admitted to these settings in the past, to really help us think about what are strengths, what are weaknesses, what are areas for growth, right? To then help us inform next steps of where to go. So yes, there are some strengths, right? So what are those? 1, less wait time. Many generalized settings have partnerships, right? Whether they are partners with community mental health centers or big behavioral health conglomerates in the outpatient setting that can then come and provide care and help with that step down and transition. One thing that some of our autistic stakeholders said is, it actually, despite I may not have liked my peer patients, I actually like the fact that, you know what, I'm autistic and I self-harm, and guess what? They self-harm too, right? And we're all there for the same reason, right? So they actually saw that there was some benefit in being with their peers because, again, they felt, I'm not alone. Even though I have autism, other people have the same symptoms, have the same behavioral health struggles, engage in the same self-harm like I do. Again, I've already talked about this, but respite for family in crisis. And then what are some barriers? Again, kind of doing a summary of some of the feedback we've gotten already, there are some very significant barriers that would have to be addressed, right? There's patient specific, right? So autistic individuals have unique needs and unique profiles that need to be accounted for with respect to treatment that these generalized settings may not, at least now, be able to handle, right? Because they often have, not a one size fits all, but pretty much everyone gets a similar intervention. Everyone goes to the same groups. There may be minimal individual therapy, right? So everyone gets the same thing. That may not be the best for our autistic patients, right? There's unit specific concerns, right? Some of these units may have minimal resources. The stay may be too brief. There may not be a place where the patient can go for a respite. I know that the hospital that we piloted some of our work on that we're going to get to, initially patients could not go to their room. After they woke up, the doors were locked and they were only opened when it was time for bed, right? So kind of thinking about, you know what, taking a break in your room, it is a sex-safe room, is okay, right? That is okay. And if the unit is overstimulating, providing a break can be very therapeutic, right? And then there's some staff specific concerns, right? And I see a typo in there, which is going to drive me bonkers, but you know, they might have limited training. They may be nervous. They may be not prepared, right? So then the next step was like, okay, so what are the needs? Where do we go from here? So we know the strengths, we know the drawbacks. What are next steps? Again, so summarizing across all of our stakeholders, what did we find? So one, you know, I think you'll see some of these across all the groups, but one, got to have a better understanding of autism. Parents, I had one parent that really told me, you know what? My child was there for 10 days. I wasn't able to come visit him except for one time. That was on the weekend, and I can only come from 6 to 7 p.m. And you know what? I have other kids and I'm a single mom, so I couldn't do it, right? Or I had another parent that said, you know what? My child was there and I didn't know how things were going until the day they called and said, guess what? Come pick up your son. Oh, okay. All right, sure. I'll be there in a jiff, right? So really thinking about, we need to increase parent involvement and communication because they are their child's best advocate, and they know their child probably better than any of the professionals on the unit, for sure. Right? Having autism-friendly resources. This next one, reduced wait times, is really specific to kind of the emergency department. But, you know, I had a parent that told me, and then also an autistic participant that said, I was in the emergency department for 8 hours. I didn't need anything during that time. I was about to lose it, not just because I was hungry, but that was busy. There was fluorescent lights, and I kept seeing people going in front of me, and it made me upset, right? We need to have a clear plan at discharge that encompasses all concerns, not just the staff concerns, but the individual's concerns and the parents' concerns. So then looking at staff and the administrators of hospital settings, this was not that different, right, than what we've already seen. Certainly more resources. One thing that, you know, some of the staff and the administrators said is, you know what, we have a lean staffing model. Sometimes when we get autistic patients or boarders, they require a 1-to-1 or maybe even a 2-to-1. At least right now, that's really difficult. So kind of think about, how can we assist them to improve care? Number one, you might have to have a higher staffing model, and that's okay, right? So how do we do that? What resources do we pull? How do we set up a program to where there are float staff that can come in and help, right? And I think one thing that a lot of them often said is, you know, we're not autism experts, right? So training is great, right? Going to a workshop is great, but that's not enough, right? Giving us resources and giving me a little visual is great, Dr. Fodstad, but that's not enough, right? I need more than just, hey, here's this token board, go use it, right? You know, I don't know if I'd be able to adapt that, right? So how can we provide them with those resources? Number one, consultation, right? Having access to providers that have specialty training in autism. How do we do that? And the last one, so actually talking to the patients themselves, right? Those that have lived this experience, right? So what are their thoughts on this? And I think, you know, a lot that they said is, you know, remember, I may have autism, but I'm still a person, right? You know, and all of this is not due to just me being autistic, right? And you can't just blame it on my autism, because that's not an excuse, right? There's other things going on that need to be addressed. And I think that a lot of the people that we talked to that had lived that experience really said that they felt that some of the care that they were given was not appropriate. It was, you know, oh, so you gave me a token board. I'm going to say that you're going to see a picture of a token board on one of our slides, but kind of thinking about, you know what, I don't need a token board, right? I may need some other resources, but a token board isn't for me, right? I may not need that. And that's okay, right? Again, thinking about there needs to be accommodations that are specific to that individual, their unique needs and their unique abilities. So where to begin, right? So we started a pilot kind of based on all of these findings, taking in all of the literature and kind of thought about, all right, where are the next steps, right? How do we start this? So the two areas that we felt, well, actually three that were the most needed was increasing access to autism-aware psychiatric care, right? And number two, guidelines or protocols that can be implemented in fast-paced healthcare systems. So we started to target those. And one of the first places we start was, of course, training. So we developed our self-paced modules. We provided some focus lunch and learn, some brown bags, some workshops for providers. We also then started initially just a free online office hours, 2 days a week, very brief. We quickly realized that that needed to be every day, right? So now we have a program that is not necessarily 24/7, but it's 7 days a week, right? During regular business hours, where at least for our pilot programs can call, they can consult with autism experts, whether they be psychologists or psychiatrists, and they can get assistance. So the next set of slides, we're going to talk about some of those assessment and treatment targets. Again, some of these are kind of broad, as well as kind of thinking about, I'm taking a lot of this stuff kind of based upon what we've done, for better or worse, right? Kind of telling you what has worked for our pilot program at IU School of Medicine and IU Health. To kind of help you start thinking about, well, where can we make changes, right? Where can we start to improve care wherever you happen to be coming from? So the first step is the initial admission, right? So the admission interview with caregivers. So what we're talking about is primarily in the emergency department, because for most general psych units, people have to come from the emergency department. They have to meet medical criteria for admission. So that first interview has to really focus on their preferences, the preference of the autistic individual. So foods, objects, activities, really has to focus on how they communicate, their reinforcement systems, what gets them going, what motivates them, and early warning signs of their agitation, as well as what has worked well in the past in hospital settings, right? If they've ever gone to the hospital for surgeries or for dental visits or for eye appointments, what has worked in the past, right? What are things that has helped these very difficult situations to go a little bit easier? So the first step is kind of what we really did, is really trying to shore up that initial admission in the emergency department. So we created a behavioral health intake questionnaire. And I want to stop right here and note, this is done, well, yes, it had the intention to be done for only autistic individuals that presented to the emergency department. This is now done for every patient that presents to our child hospitals or our adult hospital, in our county hospitals, in our healthcare system, for any person that presents with behavioral health needs, right? They're in a psychiatric crisis, right? Because our providers really said, you know what? This would be helpful for anybody, not just for autistic individuals, right? So let's do it for everyone. So now it's being used across the board. This is embedded into our electronic health record. It can easily be brought up. And the cool thing about this is once it's completed, one, it can be edited in the future. And two, it is a living document that stays in the person's electronic health record. And recently we added in the EHR a way to flag these. So anytime there's been one of these behavioral health or the BHIQ that's been entered in, it lives in the electronic health record. When you open up their record, there's a little red flag that comes up and says, BHIQ has been completed. Please see for resources, right? Anyone can pull that up. So if they're going to a dentistry appointment, they're having a sleep study, right? They go to an eye appointment. They have to go for a procedure and they're going to stay on the medical floor, right? They can pull it up. They can see, oh, all right. So, they went to the ED for psych reasons one point, and they said that this is how I'm supposed to communicate with this person. These are their motivators. This is the type of medication that works for them. They can't take pills. They take liquid, right? They like things that taste great. Can we make it like that, or put it in pudding, right? These are things that can help across the board in settings and make a wide variety of medical scenarios go a lot better. Then with respect, again, to that initial admission, we also felt there were 6 main areas that we needed to address. So one, got to have expeditious care, right? We got to get them in. We've got to get them to their rooms quickly, and we need to triage them in their room. So in our emergency department, at least at the child hospital that I work at Riley Hospital for Children, we have a separate behavioral health. It's called the BHAC. It's the Behavioral Health Access Center. That is a 6-bed unit within the hospital that is for individuals with mental health concerns, and they are presenting for psychiatric reasons to the emergency department. So when they come into the hospital, into the emergency department, they're taken immediately there, right? And when they're in their room, they can do the BHIQ with the licensed clinical worker or with any sort of staff, child life, the psychiatrist. If there's a psychologist on call, anyone can fill that out. Or there have been, and we just started a pilot of being able to send that BHIQ. If parents call in and saying, hey, I'm bringing my child in, we will text them a secure text system that we have at our healthcare system, that BHIQ, they can complete it, and then it's immediately embedded into Cerner, which is what we use, our EHR, and then it can be used by the team ahead of time so they can prep things. The next one is we want to reduce environmental triggers. So if you see the top right kind of picture at the top, this is actually a picture of our Behavioral Health Access Center. We have this cool little light instead of fluorescent lights that can be used in the event that we need to have a low stim environment with respect to lights. We also have taught not just our emergency room providers, but also our acute psychiatric unit to use the see, hear, feel, speak method. And if anyone's interested in learning more about that, there's the reference there. And that is a method that was actually developed for dental visits for autistic individuals. And what it really looks at, it really teaches providers to really think about all of those different areas that are important to modify. So the first one is we want to see, we want to try to think about what are things that could be overstimulating that they're in their environment. And we want to modify that. So certainly with respect to lights, it being busy, I think number one is having too many people in the room, right? So how can we modify that? Auditory, so here, how can we dampen noise? Our BHAC is fitted with each room has their own little customizable, you can MP3 player so they can play their own music, feel what are certain textures or things that they might need. Do they need a weighted blanket? Do they like certain temperatures? And then speak. So what is the language ability of the individual? And then modifying our own language to match their needs and match their level and match their unique profile, right? And how can we support their communication, right? Do they need a PEX board? Do they use Proliquo on an iPad? Because we have those ready, right? Or if, or they can bring their own, right? So we want to support that. Number three, we want to provide early and clear information on expectations and outcomes. So this was a video on the right, recently embedded on our emergency department home frame, where they can see this, what can you expect in the emergency department? We want to clearly communicate needs to staff and providers. We have a resource library of all of the different things that they might need, or tip sheets or visuals that they might need. And then we want to support the actual parents' needs and the autistic individual's needs. Step 2, we want to increase and screen for medical etiology. And the reason for that, there's a high correlation of behavioral health needs and medical concerns in the autistic community. There's a greater prevalence of neurological disorders, sleep difficulties, GI problems. We once saw a girl on our general psych unit who I've never seen someone as impacted as this little lady was, right? And kind of thinking about kind of those medical reasons. Even if someone has a history of behavior problems, if we see a sudden explosion of behaviors, right, that isn't at the intensity that it generally is at, I kind of tell my staff to kind of think about, something's up down in Bethlehem, right, and there's something up that needs to be assessed, right? We need to figure that out, right? So we want to be able to screen and have the ability to screen for these medical reasons that could be compounding this psychiatric crisis. We also want to assess for and treat co-occurring psychiatric disorders. Now, this is difficult because there's not a lot of measures out there that looks at mental health symptoms in the autistic community, right? So certainly an area for further research. We have kind of taken this a few different areas. One, we have modified the DMID, which is the Diagnostic Manual for Intellectual Disability. It just came out with the second one for a checklist of common symptoms and common conditions that we may often see in those with intellectual disability. We also have some other checklists that we've made for individuals with autism, that they could kind of ask and think about. And I think one thing to think about is a lot of times really thorough, like standardized psychological assessments, if they're there for 24 hours or if they're there for even 7 days on an inpatient unit, may not warrant having a full standard battery of assessments, especially if some of them may not be normed for this patient population. And then again, we want to contact autism specialists in the system as needed for consultation and support. Step 4, we want to support their communication, sensory, motor, medical, and safe and self-care needs. Again, so certainly individuals with autism is a very heterogeneous community, right? So really knowing what are their needs, what are their profiles, what are their areas of strength, and what are their areas where they need help is going to be vitally important, right? So in our emergency departments and on our psych units, we have a resource library of certain visuals from the one that talks about when I go poop, to, I'm having a PICC line put in, right? So what does that mean? A social story, to I'm getting an x-ray, or maybe I just need to communicate. I'm so physiologically aroused that I can't ask for a break. You know what? I can hand a card, or I can flash it, or I can have a sign, right? To having a big closet that's full of sensory items, or that can help with sensory overload. So we initially, on our child unit, piloted having a bunch of sensory items. So certainly access to headphones or fidgets or weighted lap blankets or other things like that, little handheld massagers, other things. And what we started to see is, well, you know what? This is helpful for all of our patients. So I also think that kind of helped with normalizing some things. So now all of our patients, regardless of their status of if they have autism or not, when they're admitted, they get to go to our sensory closet and pick out a few things starting out, right? So again, so there's many kids on the unit, some with autism, some without autism, that may be using headphones, right? Or may use a fidget, or may need different type of seating, or may need to use a chill zone pass, right? So kind of helping to provide that support of, they're not alone in this, right? Provide some relief and some support in that area. The next step that we want to do is conduct a behavioral assessment, right? So what does that mean? Meaning that, again, thinking about that iceberg, right? We saw that iceberg kind of picture that all you see is the behaviors and there's all this stuff down here. How do we start to figure out all this other stuff? So certainly getting a good history can be a good way to do that. The next way, especially if they have behavior problems, so aggression, self-injury, property section, can be to do a behavioral assessment, but also thinking about, they might be on this unit maybe 7-8 days that may need to be brief, right? So how can we do that? So we have taught our staff to use a variety of indirect assessments. So these are things that they can complete with the parent at the admission on those targeted behaviors, right? So tell me, what are reasons that are related to your child's aggression? If you do they tend to have aggression when you tell them no, they can't have something, right? So using the FAST or the questions about behavioral function are some measures that we've used. The next one is kind of doing some observation or in vivo data collection. Interestingly enough, on a lot of our units, our staff are already used to doing anywhere from 15-minute checks to hour checks on all of our patients. So really thinking about that can lend itself to being able to give some rich data. So we actually taught all of our staff to take scatterplot data, right? So if anyone knows anything about scatterplot, it's this one right up here on the top right. That's a really good method for finding time-based relationships to behavior occurrence, right? So Sally really is only having behaviors at 8 o'clock in the morning, right? More often than not, right? So then that can say, well, what's going on then, right? Oh, that's when she has to get up, get dressed, take her vitals, take her shower, all of those things. And we know that that's already difficult for her because there's a lot of hustle and bustle going on the unit at that time. She might be overwhelmed. She may not know what comes next. She may not like to wait for vitals. So let's see how we can program around that. That's been really powerful for a lot of our staff, and they've been able to be independent in that. And then the next one is kind of using ABC, right? So again, antecedents, behavior, consequences, using a very easy method that a lot of our staff have been able to use quite well. And then the last is providing a very clear summary of that. So this is, if no one has seen this measure, I really love it. It's called the iceberg assessment. It was actually developed on an autism specialized unit at Colorado Children's from Gabriels and Barnes in 2012, but it's a nice way to summarize all of those things that you have found that are related to behavior or psychiatric symptoms. And it's a good summary of all these different areas that you really need to think about. So on our behavior plans, that's the first page that our staff see, right? And some staff don't read the rest, which is fine because that's a really great summary and that gives them all they really need to know. Then step 6, we want to adapt our environment and programming, right? So a lot of general psych units have level systems, right? Or have reinforcers that may not be personalized to our autistic patients, right? So in the unit that we have kind of piloted some of this out, we have a STAR program, which is modeled after the same reinforcement system as their non-autistic peers, right, on the unit, right? So it's the same thing, just looks a little bit different, is a little bit cleaner. We also have sensory areas where they can go if they're distressed in our unit. So this is one of the new adult units in our health system. We have different types of seating. If you look all the way in the back, there's a little alcove in the milieu, right? So giving them schedules, very clear, this is what you can expect. And I will say, all of our patients across our system on our inpatient units get daily schedules, right? So it's not that much different from their patient peers. It just may be a little bit more customized to their needs. And then additional considerations, right? We want to incorporate structured educational services. So for a lot of our children with autism, they have behavior problems in school settings. So if we're not testing that and giving parents strategies or school strategies, then that admission may not have been the most helpful. We want to continue not just doing one training, but multiple and ongoing training and access to resources for our staff. A longer length of stay may be needed, right? And that's okay, right? To be able to really address the patient needs, the family needs, the school needs, and hooking them up with services in the community. We might want to reconsider medical necessity for inpatient psychiatric care for our autistic individuals, right? self-harm, or, kind of how long that's happened, or kind of being able to talk about their feelings, that may not be the most appropriate, right? So what is? And then we want to involve the patient and the parent, right? Or their support system in treatment during stay. So here is a brief summary. And as we get to that, I want to make sure that we open up the floor for questions and answers. So I'll just keep the summary right up here. And then Jasper, if you want to go ahead and start with the Q&A, this would be a great place to do that.
Great. Well, thank you so much, Dr. Fodstad, for such a wonderful and illuminating talk. I think that this is such a topic that is clearly of interest to many of our attendees, as well as the broader community. I think that map that you showed at the beginning of the lecture, showing the autism inpatient settings, and just showing that, the limited amount of inpatient settings that are available for these patients is really, really jarring to see and very important. And so, upon reflection and thinking through some of, the takeaways that we want, actually want to allow you to do some of that summary. And then I want to remind our attendees, while Dr. Fodstad is wrapping things up, to type your questions into the Q&A for our chat. And then for everyone, before you leave, to make sure to complete our evaluation survey that will be dropped into the chat. Or once you leave, you will be redirected to complete that survey. And so with that, Dr. Fodstad, do you want to kind of leave us with some takeaways, and then we'll start off with that Q&A?
Sure. I want to say Dr. Lageson said that she can't access the Q&A. I don't know if any other people are having difficulties with that. So I guess maybe if they are, they could type them into the chat. I don't know, but just a thought. But sure, okay. People are coming up with the questions. Here's just my summary. So one, I think, there are limited options for specialized autism psych care, right, in the United States and abroad, right? So I guess thinking about if these services are needed, the most likely place that they're going to go is their nearest emergency department, and they're more likely to be admitted to non-specific, so non-autism psych units. So we have to think about, one, can care be successfully provided? Yes, it can, but certainly adaptations need to occur. And so what are those, right? And they need to best meet the needs of the individual, the staff, and the family, right? We need to address all of those individual and unique features of the patient. And we need to be able to provide the staff with ongoing and additional resources, training, and consultations, so that they can feel confident, so they can feel like, yes, I did a good job, right? Yes, I did provide a meaningful care to this patient, right? And so that then the next time a patient with autism comes, they're like, I know what to do, right? I feel empowered. I have all of these resources. I have all of this training. Guess what? I can call Dr. Fodstad on the phone, and she's going to help me get through this, right? We need to be able to do that moving forward, right?
Absolutely. And I think that BHIQ, is that what that was called, was such a wonderful place to start in terms of the intake process, getting some details on, what the interests and needs are of that individual patient. I think that is a great takeaway. And that's very much aligned with some of the questions that we're getting in the Q&A about what are some tools or ways to help take easy data. So once these patients are admitted, what are some ways for those providers to take easy data?
Yeah. So the way for them to take easy data in the emergency department, was that the specific question, or just in general?
A specific question. Yeah. Easy ways to take data.
Yeah, so I know this sounds bad, but I love quick and dirty data. I love just observing what I see, right? Those ABCs. What happened right before this person got upset, right? This is what happened. What did I do, right? What happened? What happened in the environment? Oh, Johnny got upset when not only the ED doctor, but all of the residents came in, right? And it was like a gazillion people, like, let's write that down, right?
Mhm.
One thing that we've started in our emergency departments, and I don't know if you saw it in another slide, but when the ED doctors or the ED staff figure that out, they write it on the wall or they post a picture, like there's a picture of someone going, shh, right? So we knew this kid really didn't like loud noises, right? So we put that right on the door, right on their chart, right on their window, so that anyone going in knew that, right? So a lot of times, I think for most staff, teaching them, you can take data the quick and dirty method, like what are you seeing, right? Write that down, can be very powerful for them.
Mhm. Excellent. Right, because ABC data, it's low tech. You can quickly write it down on a post-it if needed. So I agree that those are definitely easier ways to track some information. Another question is, how might some of these findings be applicable to other settings, such as in schools?
Yeah, so I do think that some of these findings do have applicability to schools. I think also thinking about, in the school system, our autistic individuals have unique needs that need to be addressed for sure. And they also have psych symptoms as well that co-occur with their autism that may not be adequately being addressed in their IEP. So for sure, I agree with you. I do think a lot of our findings and kind of what we're doing has a wide reaching effect. And maybe in 10 years from now, kind of the research will be there, or I'll be able to extend some of these findings. But at this point, I'm not there yet, unfortunately.
I know. I think that this is really highlighting that there is such a need for ways to continue to serve this population. I know that there's also emerging literature and work done in outpatient mental health settings that is doing similar kind of trainings and consultations for general mental health therapists that are working with individuals on the spectrum. So, in higher levels of care, this is certainly needed, because I was also struck by some of those numbers that you had shared, Dr. Fodstad, that autistic individuals are 11.9 times as likely as non-autistics to be inpatient hospitalized, and so that was really jarring for me to see. Another question that we have here, there's so many wonderful ones here, is are there any recommendations or references for psychiatric inpatient units that are looking to adapt their environment?
Yeah, so there are some references out there. A lot of them I actually will say are in my talk, which I do think you'll get access to.
Mhm.
And I will also, so I didn't do this, I didn't add a reference list, but I'll go in and add that before I give it out. And then I'll make sure that I put a point, like if you're looking for more on this topic, look here. So it'll be an additional addendum to the presentation. I do know at NYU, they have presented they have published some things there.
Mhm.
So that is an area that you could look, and that was on one of the slides there. I had one of the references there, but I'll make sure when I send it out for those what you get, I'll put like a special page. It's like, if you want to know more about this, look at these specific references for sure.
Perfect. Thank you, Dr. Fodstad. And yes, just to build on that response, the slides will be available on the Tarjan website, as well as the recording on our YouTube and on our website. So be on the lookout for everyone for those resources. And then to wrap things up, Dr. Fodstad, last question, any research about COVID as a predictor of psychiatric hospitalization in children or adults that are on the spectrum?
Yeah, I will say that there hasn't really been a lot of data on psychiatric inpatient admissions being increased during COVID for autistic individuals. I mean, I do think what we have seen is just more globally, all children, we've seen a higher rate of that just across the board. There hasn't been any specific ones on autism. At least I'm thinking about me personally in my own outpatient kind of setting. I will say, a lot of my patients initially were kind of okay. They actually started to be better at the beginning of COVID, right? Because that social demand was definitely lessened. I do think as COVID has prolonged, they've started to kind of have a lot more kind of mental health concerns or difficulties, but there hasn't been any data in that. And I did kind of look at kind of what our own ED data said, and it didn't really show any statistically significant differences, right? But that's just from our children's hospital data that I actually looked at before this talk.
Yeah, I mean, I think that that's great for researchers and clinicians out there for us to reflect on in terms of, how are we building upon these experiences that we've had throughout the course of this pandemic and how we can better address the needs of each of our patients. All right, well, thank you so much again, Dr. Fodstad, for that wonderful talk and for presenting to us all the way from Indiana. It was lovely to see you and to have everybody here with us today. If anyone has any questions, please feel free to contact the Tarjan Center. We would be happy to follow up, and be sure to keep an eye out for the recording as well as the PDF and slides for our wonderful talk in the near future. All right, thank you, everyone.